Hi everyone. Today we're talking about the surgery, the section of urosurgery, and the topic is vesiculouretric reflex and mega ureter. The VUR, you can see here the contrast image. Present, you can see the dilatation of bilateral ureter until the kidneys. When we talk about the prevalence of reflux was estimated to be approximately 30% in the children with UTI and 17% of this without infection. So when there is increased percentage of UTI, there is increased percentage of VUR. VUR may be the cause of UTI, so each one can cause each other. What about gender? During the first year, most are boys with posterior urethral valve. After 1 year of age, the female to male ratio of children with infection and reflux is approximately 3:4 to 1. The race relative 10-fold lower frequency of reflux in female children of African descent. Inheritance and genetics. The prevalence of the reflux is higher in siblings. A recent meta-analysis of siblings reflux studies suggests the prevalence of the VUR in the siblings to be approximately 32%. The mode of inheritance is autosomal dominant, and the mode of important question to be asked. The history of the patients with VUR is: does the patient have family history or family members with VUR or not? Also, when talking about functional anatomy of the anti-reflex mechanism, the phenomenon of VUR presents a balance of the several factors. The factors include the functional integrity of the ureter, anatomical composition of the UVJ, it's vesicular junction, the functional complaints of the bladder. You can see here, explain the reflex level, and here there is no reflex. Here the possibility of reflex, here the reflex is unsure. Etiology of the vesiculouretric reflex. We have primary and secondary. Primary, it's the anatomical causes. If the main reason of the reflex is fundamental deficiency in the function of the UVJ, causes a trigonal weakness and the familial reflex. Secondary, it's functional. The primary was anatomical, the secondary is functional. The bladder dysfunction of the congenital, acquired, or behavioral nature is frequently the root cause of the secondary reflex. Causes: ureter abnormality, complete urethral duplication, ectopic urethral orifice, and urethrocoel. Second, voiding dysfunction and iatrogenic abnormalities like a prostatectomy, wedge resection of the posterior vesical neck, urethral myotomy and resection of the urethrocoel, contracted bladder. Complication of the reflux. Vesiculouretric reflux damage the kidney through one or both of these. The first one, pyelonephritis and hydrouretronephrosis. There are three reasons for the dilatation: increased workload, high hydrostatic pressure, and weak urethral musculature. This the grading description of the VUR. You can see here we have 5 grades. The first one, the reflux into the non-dilated ureter. Here there is no dilatation. The second one into the pelvis and the calyces without dilatation. The reflux will reach the pelvis and the calyces, but there is no dilatation, you can see here. The third one degree, it's mild to moderate dilatation of the ureter, renal, pelvis and the calyces with minimal blunting of the forces. Third, we can see there is minimal dilatation, reach the renal pelvis, the calyces with minimal blunting of the forces. The fourth degree, moderate urethral tortuosity and dilatation of the pelvis and the calyces. Here there is dilatation more than level 3 and the tortuosity here is somewhat appear more than this. The fifth one, the last one, is a growth dilatation of the ureter, pelvis and the calyces, loss of the papillary impression and urethral tortuosity. You can see here very clear tortuosity and dilatation as we see in the first page here. You can see it's clear dilatation and tortuosity to the pelvis and calyces. That's it for all. Thank you.